informed me last night that I had to give a speech, so if you don't like it, you can blame it. It's really an honor to be here, and it's great to be home again. If it's true what they say that early childhood experiences shape your life, one has to wonder if my precipitous delivery in the Mary Fletcher Hospital elevator may be what influenced my decision to go to study medicine at UVM and then go on and have a career in obstetrics and gynecology. All joking aside, what an amazing institution. I'm forever thankful for the education I received here. I had many excellent role models along the way. My father, Jack Hansen, who came to UVM to work with Drs. Amadon and Tabacon in starting the cardiology division. My mother, Margareta Denker, who in her midlife, made a choice to become a human rights advocate and traveled to Turkey and Syria to witness and document the atrocities against the Kurds. My husband, John, children Rose and Michael, my siblings, the very large Kennerson clan, my med school friends and community, whose love and support has brought me along the way. And also the many leaders here at UVM, and I'll just pick one to highlight, Dr. Jerry Bellinson, a GYN oncologist, whose humanity at the bedside of patients facing a poor prognosis was an invaluable life lesson. In my 25-year career in women's health, I never lost a mother to complications of pregnancy. Great colleagues, access to advanced imaging, laboratory, and blood bank services supported me along the way. Around the world, that's not true. 1,400 women die daily in a birth-related event. That's 1 a minute. 4 by the time I'm done with my speech. In Haiti, 1 in 16 women die in pregnancy, and the effect it has in this matriarchal society where a child under 5 survival is heavily dependent on his mother is devastating. Within 24 hours of arriving in Haiti, I was told it was senseless to waste what little oxygen there was left in the tank on the preterm baby that had just delivered. A baby we easily would have resuscitated successfully here at home. A day later, a woman arrived at the hospital, having walked through the night over the mountain with her newborn tucked under her arm, an umbilical cord dangling between her legs, and an undiagnosed twin still in utero in a transverse lie. I think when I told John I would need his help with this delivery in the operating room, that was the day his hair turned white. Fortunately, both the mother and both twins and John survived. 2 days later, she left with a baby tucked under each arm to make the long trek home. Experiences like this are seared in my mind and are hard to ignore. In 2008, I led a team to Haiti in collaboration with the International Society of Ultrasound and OBGYN, Partners in Health, the Minister of Health, and generous General Electric corporate support for basic ultrasound training of 28 nurse midwives and OBGYNs working in 10 sites in the very rural and isolated Central Plateau of Haiti. I have since then led teams to Ghana and Somalia to provide similar educational programs. 2 GE executive observers came on our second of 3 planned trips to Haiti. On their journey to the Central Plateau, they came across a group of men carrying a woman on a door, a common makeshift stretcher in Haiti. She was pregnant, had started having eclamptic seizures, and was now obtunded. The men had been walking for 4 hours and had another 2 to go before reaching the closest hospital. When the GE executives understood the situation, they gave up their Land Rover so that the woman could be shuttled to the hospital where she was delivered and miraculously survived. The baby was not so fortunate. Building on this lesson of solidarity, GE has now fully equipped a new 300-bed hospital built in the Central Plateau after the earthquake. So it is clear to me that though my entry into the world was not so graceful, I did win the birth lottery. And as a breast cancer survivor, I benefited from early detection and aggressive treatment that is not yet available to our sisters in the developing world. And as a segue to John, on January 12, 2010, I was in Haiti for the 3rd ultrasound training when the earthquake happened.
So let me continue the story, and Dr. Kunin, I think I found you 10,000 words. After the earthquake, we returned to Port-au-Prince to see the good, the bad, and the ugly, and left with a gnawing existential question as to the future of medical volunteerism. It was obvious that there needed to be a system beyond simple ad hoc and unorganized medical tourism. After a period of discernment, I elected to step down after more than 20 years as medical director of the cardiovascular division to take what I had learned about quality, value, appropriateness, clinical effectiveness, and focus on building a system to build back together in Haiti. We recognized that we needed a system for communication that went beyond the usual nodal points of control, but fostered open communication for collaboration. With an IBM Trailblazer grant using a Smart Cloud platform, we had that tool for dialogue and focused, goal-directed communication. This is essentially modified crowdsourcing with a meritocracy twist based on the primacy of knowledge and not simple hierarchical titles. We recognize that it is only via collaborative communication that we'd be able to build the digital, temporal, and service colleague-to-colleague horizontal bridge of mutual respect between our colleagues who wanted and desperately needed help and those with the knowledge and expertise who were willing to help. This was the genesis of Colleagues in Care, and this is where the UVM experience came to the fore. Georgetown ethicist Pellegrino Tomasma speak of the spectrum of medicine as a job or career, a helping and healing profession, or a vocation. We have been exposed here in Vermont to the highest aspirations at the right side of the spectrum. As you look around, Drs. Haynes, Mazuzin, Dr. Tampus, Dr. Reardon, Dr. Kunin, Dr. Kaufman, and my mentors in cardiology, and our contemporary colleagues, Margaret Rule, Jim Hebert, Ira Bernstein, the common thread was an overt and infectious passion to teach, to learn, to treat, and to serve. I hesitate to mention this in the presence of Jim Hebert, who was quoting Latin at dinner last night, but as one evaluates the etymology of the word passion, it comes from passio or patior, and it reflects suffering. For those of us who are infected with the medical passion for the alleviation of suffering, and it was at University of Vermont where we also learned the difference between caring and curing. In a developing world, we're not always colleagues who cure. We can argue about the politics of access to health care as a human right, but we all should agree that we need to do what we can to avoid stupid deaths that are due to easily treatable disease. From the bottom billion, being the destitute poor should not be a potential capital offense. People talk now of social determinants of disease and global health. Well, we heard that message from Dr. Charlie Houston from the very first year, and continuing dialogue up until weeks before his death, as a nearly blind but still insightful nonagenarian, continued to ask the sometimes irritating and uncomfortable but always challenging questions that we struggle to answer. We have developed a taxonomy and a lexicon for the common language of best possible practice as the marriage of evidence and reality-based medicine. As an interventional cardiologist, fortunate enough to train in nuclear here with Dr. Wackers, it was a challenge to find yourself in a country that had no electricity, where nutritionally insecure people died before the age of 50, and you had to, you were stripped down to your stethoscope and your blood pressure cuff. We decided to focus on hypertension and the horrendous surrogate endpoint of stroke. Befitting the medical school of Harriet Dustin, 2 weeks ago at a joint session of the American International Society of Hypertension, it was announced, our collaborative effort was announced as the Integrated National Haiti Hypertension Program, combining education, research, training, standardized protocols and formulary, and based on simple quality metrics. This will be the model for the Caribbean and beyond. Through Lisbeth's and others' efforts, there's much more to follow, and after many discussions here this week, we hope that UVM will join the expanding network. Let us finish my discussion of the push-pull dynamic of collaborative learning and where we are going. Disruptive technology becomes disruptive innovation, or in the sense of social entrepreneurship, catalytic innovation, when it is easy, available, at low cost, and answers the basic question of how can I do my job better? For Colleagues in Care, it is basically a how-to of mutually shared knowledge. When is the last time that any of us treated, well, with some obvious exceptions, have seen malaria, cholera, dengue, or typhoid? Our colleagues are asking that we do not dumb down education and learning, and do not confuse low resource for low intellectual curiosity. Their voracious appetite for knowledge and training needs new paradigms, and they need to go beyond classrooms to metaphors for the pull of self-directed learning that more reflect the amalgam of the library and the town hall. It is also an approach to decrease the brain drain of bright physicians and nurses to the developed world. It's not always purely financial. We need to support those willing and anxious to stay and serve their country and their people and to do it well. Imagine a place where colleagues stand with colleagues in a mutual sharing of knowledge, which at the end of the day should be a professional right. We have imagined that place. As we bring the sometimes ephemeral concept of cloud-based technology systems to the ground via mobile technology and modified 40-foot container education and simulation centers of medical knowledge and training, we believe fervently that there is hope for collaborative learning and service. We hope all will walk with us on that journey. It is thus with a sense of profound humility and gratitude that we're here today to stop and reflect on the tripartite message of service, medicine, and community that is at our very core. For the University of Vermont, thank you for teaching us the humility of service. Thank you for sharing your medical passion for the honor and privilege to be members of the helping and healing profession of medicine. Also, special thanks to Dr. David Tormey, our Dean of Admissions, for allowing us to share in this very special and unique University of Vermont community, our primal community of colleagues who care.